It is my pleasure to introduce our first speaker, Dr. Hamid from Angela's Clinic. He is a melanoma expert. A lot of you haven't heard of him because he's not the typical person that you refer to. Dr. Hamid is amazing. I can't say enough about him. I refer patients to him. My biggest thing is he's not afraid to try something, and he's not afraid to think out of the box. So I encourage you to reach out to him if you have questions. If you are a metastatic patient and need a second opinion, he's absolutely awesome. So we would like to thank him for Angela's Clinic for partnering and helping us make this happen. So without further ado, Dr. Hamid from Angela's Clinic.
Thank you. Turn around. It's a real pleasure to come and speak with all of you. I just wanted to thank Ocular for allowing me to speak, and for all of you to be here listening. I think ocular melanoma is at a time right now where we're on the precipice of some major breakthroughs, and that not only comes from discovery focused towards ocular melanoma, but this whole idea now that we have in oncology that all tumors are not the same, but there is sameness within them. So either genetically or their makeup or immunologically, and the ability for us to be able to see that in our basic research and in our clinical trials is allowing us to find answers for patients with ocular melanoma. Now my talk is a fairly straightforward talk about clinical trials, which is what I do at the Angela's Clinic. I'm a medical oncologist who has a background in immunotherapy and drug development. And through our program, we've had the benefit of working with lots of the drugs that you hear. And I always find it interesting that they always focus on the fact that these drugs are great for skin melanomas or lung cancers or kidney cancers. But ocular melanoma is welcome into that sphere. And what we're going to do today is just go through a couple of some information about these drugs. I don't need you or want you to in any way write things down except for this. My email, my cell number is here. If anybody has questions or decides to ask further, please feel free to contact us at Angela's or me specifically. It just is, I thought, the best way to begin with a offering of hope and options for ocular melanoma. Because I've been here with other patients, with other tumors, with other diagnoses where the feeling was that there was nothing to do or there wasn't future options. But in our place, we actually really through our program and through partnering with other institutes such as Memorial Sloan or Columbia or UCLA or others, have been able to get our patients to future therapies that can be beneficial. So these are my disclosures. Always the most conflicted guy can give you the best, most uninhibited discussion. So we've opened our clinic to partnering with multiple pharmaceutical partners. You don't need to know this, but uveal melanoma is a rare malignancy in the melanocytes of the uveal tract. Obviously, there are differences in function of, there are differences with this drug, with this tumor as others. And it doesn't harbor the same mutations as skin melanoma. It isn't as immunologically competent as skin melanoma, but there are ways to work around that, and there are ways to take the lessons we've learned from there and move forward to take care of uveal melanoma also. Interestingly, it's a intraocular malignancy that peaks at 55 years, and it's rare. It's only 1,600 to 2,000 patients. Now, when you look at that with what normal oncologists see, and by normal I mean you open the door, you hang a shingle, and you serve the community, we're way behind breast, lung, colon, prostate, Those are what the majority of oncologists spend the time with, the majority of oncologists are focused on. And therefore, the one great thing that I can say is that you should always request another opinion, specifically when you hear that there is none or that you've come to an end. There is always another place to go. It might take time, but we can find options. The presentation obviously is visual changes. Most people say that they see spots, etc. But what is difficult initially is to find the team that can take care of you. I know Tara McConnell came and spoke here, an ophthalmologist and a unit behind her that supports the initial surgical and radiation requirements. And the concern that a significant proportion of patients, even presenting with local disease, will have metastatic disease, is now the paradigm that we use for every solid tumor. High-risk patients need an infrastructure of planning, and that's what we call it at Angeles. Whether it's looking to use a Castle test to predict risk of recurrence, whether it's obtaining tumor tissue early to look for genetic mutations that we look for every solid tumor. Why is it that when a lung cancer appears, the first thing they do is they look for mutations? It's because we found that there are drugs that target those mutations that help with response and survival. And the same for melanoma from the skin, BRAF mutations. It's the same if you show up with prostate cancer. This idea has moved even to prostate cancer, where you're looking for BRCA mutations and ovarian cancer. Because 5 years ago, we didn't have anything that targeted that. But through research, through trials, through sending those patients to these trials, we found out that, look, the same PARP inhibitor that works for breast cancer and ovarian cancer works for prostate cancer. And these are the same values that we're taking through with ocular melanoma. And this is the point to make about mutations. BRAF, you hear about in cutaneous melanoma, 40 to 50%, NRAS in about 20%. But the GNAQ, GNA11 pathway now is one that is being utilized for clinical trials for ocular melanoma. And these mutations do exist in a significant proportion of them. Let's talk about what else is there. So any patient that presents new, we would look for these. We would look for monosomy 3, it's an increased risk of recurrence. GNAQ and GNA11, there's genes in early growth, but also can be targeted with NRAS-targeted agents. BAP1 has been presented as a risk for recurrence, and also there are mutations for good prognosis. So we take these and we lump our patients into higher risk or lower risk. And that has moved on to something like this. I mean, just to show you how involved it's becoming. Please memorize this, there'll be a test on it. But as we find these targets, we're still looking for success here, but all of these targets now, AKT, PI3 kinase, PKC, MEK, all of these now have drugs that are targeting it in clinical trials. In fact, there's been a lot of data in the PI3 kinase pathway as far as multiple malignancies that respond to immunotherapy and then become resistant, may be utilizing this pathway here. All right, let's move on real quickly. Even those drugs that have been touted as working, the MEK inhibitor, selumetinib, and they've shown us responses in GNAQ mutant patients. You can see here chemo regression in 50% of patients versus Hamid, which is a chemo 11%. These trials have been done. They showed initial response, but long-term benefit was at question. And so how do we use that? Well, we're now finding that if you block this pathway, you can increase immune infiltrates into the tumors. And that's been the problem with ocular melanoma, that we haven't been able to figure out a way to make it as immunologically sensitive as skin melanoma and lung cancers. So possibly by blocking the GNAQ pathway and adding PD-1 targeted therapy. So the idea of targeted therapy plus these drugs that you hear a lot about, Yervoy or Keytruda or Opdivo, this is something that's being taken further into tumors like yours that harbor that. And then this is some initial data that's shown that even when you start a patient, this one is a colorectal cancer and this is a sarcoma patient, they don't have that T-cell infiltration. You give them a MEK inhibitor, and you can see here this is more staining for those T-cells, and then you combine it with the PD-1. So those are things that we're looking for in the clinic. So interestingly, when you say things like that, patients and colleagues say, well, show me the money, show me how that's happened. And this is a melanoma patient, belongs to, I think, Richard Carvajal, GNAQ mutant, melanoma, and development of multiple metastases responding to immunotherapy. And then, as you can see here, almost a year later, still responding. So it is rare, but it is happening, and we're trying to find out more of how that's happening. And trying to figure that out is an archaeological dig of understanding that, look, it might not be the first therapy or the second one or the third one, but ultimately stimulating the immune system multiple ways can be additive. We'll talk about this patient a little bit more later. There are newer therapeutics that are always coming out for solid tumors, and this is where a phase 1 program like ours helps patients. That is to understand that there are multiple different ways to target the cancer cell. Either antibodies, these are the checkpoint inhibitors that block an immune inhibitor or stimulate an immune active area. Antibody drug conjugates are antibodies that target a specific protein on cells. And then I call it like a Molotov cocktail. There's a chemotherapy attached to the end. Bispecifics you've heard about. Everybody's heard about these. And these I call Yenta antibodies or matchmakers. And we'll talk about this when we talk about the Immunocore drug. They bring two things together. They create a synapse, our T cells. Take the T cell, they attach a plunger onto it. And these then go looking for a protein that's specific for the tumor cell itself. And we can then talk about T-cell receptor therapeutics. But these are ways to bring the immune system to the tumor. I'll give you an example. We're going to partner with City of Hope and UCLA to send patients to a clinical trial that has CAR-T for melanoma with a target of a protein. Now, when we talk about clinical trials, there's a big push for my talk later on this afternoon. Trying to find out how you can fit yourself into a clinical trial is finding out if they include you. And this trial only takes melanoma. It doesn't say uveal, acral, whatever. So if your tumor expresses the protein that this antibody is going for, guess what? You're up for a CAR-T trial. So we're going to take all of our melanomas and screen their tissues for that. And that's a way to help understand why checkpoint doesn't work well in uveal melanoma. So that Opdivo and that Pembro that's approved for melanoma works in melanoma because there's a high tumor burden. It doesn't work initially alone in uveal because this is the lowest tumor burden of almost any tumor. The response rates are low. We don't have to stay on this. But you can see that there are certain patients that it works on, even as a single agent. This is a person who had lung and liver metastases and ultimately responding. Please excuse my pointer. The other idea is that as a community, uveal melanoma patients come together a lot, and they help each other. And as a patient, this idea of the exquisite responder, this extraordinary responder, is very helpful for people like me, because you can take this person's tumor and understand why this person responded well. Do they have a specific mutation? Were they treated with something else before? And is there something different about their tumor that made them respond? And then go back and reference that to the libraries of other patients' tumors. So that's it, not doing a big trial to find the 50% that responds. It's like doing a small trial, finding the 1 or 2 people that respond really well, and then tailoring therapy for everyone else in that cohort. So that's, again, we go through these quickly. This is how to find out, I like this, how to find out this 8% or this 4%, why were these people so special, and move them forward. And that's a great way to transition into how to move forward. Find those people, understand it. That person who responded really well, I showed you with all the metastases, had a therapy previous that made them more responsive to the immunotherapy afterwards. Skip this real quick. We are also doing combinations with other immune modulatory receptors. If you can't use one to stimulate the immune system, maybe a combination can do that. That's the whole idea of Ipi-Nivo combinations and higher response rates. But it's important to figure out which combinations, and phase 1 trials do that a lot for us. We also have this ability to use direct stimulation of the immune system into a tumor. Now, some of you may have heard about TVEC or Elijah, and this is something that's approved for cutaneous melanoma that we're taking a look at in other solid tumors. Breast cancer, lymphomas, head and neck cancers, and why not ocular melanomas. We're understanding that you can take stimulators and directly inject them into tumors and cause a local reaction that, when combined with another therapy, can cause a systemic benefit. And we've done that. We're trying that out on many solid tumors, and all of those trials allow ocular melanomas coming in. And in fact, they've started by injecting into skin lesions or lymph nodes or multiple primary lesions, but that's not what ocular melanoma has. And that's not what breast cancer has. And that's not what lung cancer has. But as we become safer and safer injecting locally, we now utilize our interventional radiologists as part of our army. So at Angeles, we have 3 of them. They sit in a dark room. And every once in a while, we ask them to be part of our clinical trials and inject these stimulators, these viruses, these immune drugs directly into liver metastases. And those clinical trials are now ongoing in multiple places. I'm going to go forward a little bit and talk to you about intact molecules. And these are sort of those matchmakers. They work to improve the cancer cell and the T cell synapse, sort of like that matchmaker that I talked about before. And this is what you've heard a lot about, but one of the most promising drugs in uveal melanoma, and that's the Immunocore drug, the GP100 drug, IMC GP100. And this is how it works. It's an infusion that's given that allows the immune system to recognize the tumor. It brings that T cell directly to the tumor itself and initiates a synapse, and a recognition and a connection, almost like a blind date. And so this is a drug that's shown improvements in 1-year survivals of patients with metastatic melanoma. It's already accrued a second-line trial. It has a first-line trial that's been requested by the FDA in order to get marketed and approved. And this drug didn't begin in uveal melanoma, it began in cutaneous melanoma. And guess what? It's already been combined with the anti-PD-1s and the anti-CTLA-4s, and it's been extremely tolerable. I know, we did the trials, and I think that that's the building blocks. These are the building blocks going forward. I'm going to really count out to the people who are here from Immunocore and Delcath and Castle and others, because they are the ones that are helping bring forth these trials for us and showing that it's important to pay attention to this population. So at Angeles, with our Cedars-Sinai affiliation, we are using these drugs. Also direct infusion, hepatic perfusion. You'll hear more from my colleague Alexander Ganji later to talk about how this can help by controlling local disease, controlling symptomatic disease, and help with long-term survival. In the field of immuno-oncology, one thing that we've really learned is those patients that have liver metastases, there's something about that metastases, no matter how big or how small, the fact that these patients have liver metastases portends a lower response and a poorer long-term benefit from immunotherapy. And so controlling disease in the liver becomes another important thing. And Delcath now is running a randomized trial, hoping to get approval. So these are the intact molecules and what I talked about, the cancer cell itself and the T cell. This drug connects to the cancer cell by recognizing a protein, which is GP100, and then brings the T cell in. Okay, it recruits the T cell, and in a normal setting, this T cell may not recognize this protein. Maybe a low affinity, maybe a very stunted immune system, and then by bringing them, it optimizes the immune connection, and then it causes the T cell to be stimulated and secrete these enzymes that break up the tumor. What we have seen here in multiple studies is an improvement, almost doubling of 1-year survival in ocular melanoma.
Is that just a single agent?
Single agent. Just the single agent itself. And these trials are being presented and represented, and we're waiting for the initial trial, the 202 study, which is a randomized study between the drug, it's now called Ventafos. You don't need to remember that. Versus investigator's choice of drug. And clearly this is a new type of immunotherapy, but it is something that's being looked at for multiple types of solid tumors. So it's moving forward in a strict way. And then also combination of drugs that we already have. Ipilimumab, nivolumab has in a trial shown a improved overall survival in ocular melanoma patients, and we don't know why, because the progression-free survival, the response is low. But I think what it is more is that we are stimulating these patients' immune systems to begin to be a little bit more competent. Sort of like those of us who have kids, when you tell them once, they don't remember. Okay, so you have to tell them twice or 3 times, and then maybe you have to take another tact to take away their phone, hit them upside the head, you know, or send their mom to yell at them. It's the same way that I feel that we are going to benefit patients. And truly, it's an interesting talk when I give this talk, because it's the same talk that I would give to any other solid tumor patient. That if the first line doesn't work or the second line doesn't work, that there is so much hope that you are, again, reset to have it's not detrimental to have seen prior therapies to then go to another therapy. And that's not a paradigm that any of us are comfortable with, because for chemotherapy, like traditional chemotherapy, losing hair, etc., chemotherapy. It was, if you don't respond to the first one, your response rates are going to be lower to the next one, and lower to the next one. And that's not true at all. When we look at immune therapies and targeted therapies, they go a little faster. Adoptive T-cell therapy is something that has a lot of foothold in cutaneous melanoma. Steve Rosenberg and the others at NCI have presented a lot of data there. And this is one where they take your tumor out and they grow billions of those immune T cells from it. They put you back in the hospital. They give you chemotherapy, not to target the tumor, but to get rid of your other T cells. And then just give you the tumor-directed T cells. And then give you interleukin to stimulate those cells. And that's done in the hospital. And we do that a lot for our patients with cutaneous melanoma. It's now a very interesting therapy for patients with lung cancer, very interesting therapy for patients with cervical cancer. But guess what? It's being done in uveal melanoma, and we're seeing response rates. And not only are we seeing response rates, these are waterfall plots, and anything that goes down is shrinkage of tumor. Not only are we seeing response rates, we're seeing response rates in patients who are checkpoint refractory. That means they've seen ipilimumab, they've seen nivolumab, they've seen pembrolizumab, and their local oncologist says, there's nothing I can give you that's standard. They've come to this therapy and they've had responses even if they've had checkpoint inhibitor. So these are waterfall plots. We look at a lot of these, but the best thing to look at, these are called spider plots because they look like a spider. Turn it this way. But anything that goes below zero is patients that are responding. And then the most interesting and beneficial part is long-term benefit. So these lines should stay down and go forward. You can see here there's someone 20 months out. And that person may have been someone in the community who had no standard options and came onto these trials. And these trials are running in multiple places, and we've actually looked to move that forward. And not only are we moving it forward in those specialty centers like MD Anderson or Memorial Sloan Kettering or Moffitt in Tampa, but through our collaborations with other places. This is a place called Iovance. Your surgeon locally can take the tumor, send it off, they can make the T cells, and you can be treated locally in your own hospital. And so this is something that is becoming more and more common. And these are trials now in lung, cervical, and cutaneous melanoma, but ocular melanoma coming down the pike. That this is that drug in cutaneous melanoma, not ocular, but the point to be made here is just like I told you before, the majority of these people who responded were progressed. Their best response on prior Pembro or Nivo was progression. 85% of those people never really had a good response to checkpoint. So there are others. These are landscape plots. They show you adoptive cell therapeutics that are coming. And for me, for patients, it shows the sheer force of pharmaceutical involvement in this modality to bring it forward. And so that's why I put these up. It's growing. Continued access to tumors helping us understand what's going on in the environment and understand how to target the environment as treatments change. This is where I talk about oncolytics, and we've done that before. The idea of attacking the immune system in multiple different ways, whether it's initially directly at the tumor or at the lymph node, and bringing all of these together. It's something that we do with EVEC and pembrolizumab. It's something that we can do with any local injectable. The majority of where we're going is not just local, not just distant, but multiple combinatorials. And not to take a lot about from the hepatic perfusion talk, but being able to continuously inject. So this is a patient with tumors in those areas. Put onto just best available therapy and progress. Moving on to a local therapy and then having a response. So you can see that from here to there. So controlling local disease helps us get to the next therapies. There's more than just one type of local hepatic therapy. You just need to just ask your doctors about it. Interventional radiologists give it all the time. Beads, radiation, chemo, etc. Injecting visceral disease and then giving the combinations are there. Although they are not as readily available locally, the combination of something given near your place and then moving on to a clinical trial and then coming back for local therapy is always an option. And when a patient comes to see me referred from their local places, I always say the same thing, that we are a group, a team working for you. Rare cancers require a team. They require an ophthalmologist, they require an interventionist, they need a radiation doctor, they need a local oncologist, they need an expert oncologist, they need a social worker. You'll meet our social worker, Jennifer Drew. They need a pain specialist. All of those things should be part of your team initially and then moving forward. And as we answer some of the questions, and hopefully by next year, if I'm invited back, we come upon those answers. In the metastatic setting, we now have to do what has been done in other tumors and move those drugs that have benefit into the adjuvant setting. Because what we've said before is that these patients who we treat at initial diagnosis have a high risk of recurrence and distant disease. And adjuvant therapy is something we're all familiar with. We all know someone who's had breast cancer, had the tumor taken out, no evidence of tumor, high risk of it coming back, and have gotten chemotherapy, hormones, and radiation. And those therapies are not the right therapies for ocular melanoma, but immunotherapy, targeted therapy, infusional therapy, chemotherapy, they're all being looked at in this setting in the adjuvant. Another plug for toxicity discussion, that sort of keeps patients away from looking for other options, and we now have a greater grasp of toxicity and how to manage it. And then a thank you for listening. I could talk for hours on this, but I would love to take questions until they tell me to stop.
Put that last slide back up. I missed your email.
Question.
Yes.
So I was diagnosed and had plaque therapy in May, and at Stanford, Dr. Hamid, great guy, and he sent me to the cutaneous oncologist, and he walked in and sat down and said, well, there's nothing we can do for you.
Who was that?
Ready, Dr. Reddy.
Okay.
And so my question is from what I've gathered, is there was nothing to do unless you start to have metastases.
Right. So the discussion, I think, should go like this. You have tissue. Did they biopsy the eye, or they just diagnosed it and gave you plaque?
No, they biopsy.
So that biopsy can be taken into multiple different ways. It can go for a Castle test to give you your risk of recurrence.
Plastic.
So that indicates to me that that's a patient that you may want to look at. If there are at the current time, and sometimes there aren't, adjuvant trials like I showed you up there, that's a patient that you then discuss if there's enough tissue to send it for a next generation sequencing to figure out if they have a RAS mutation or something weird or a high mutational load. High mutational load tumors are the ones where immunotherapy makes a lot of sense. Low mutation, you might want to look for a combination. And then you then discuss how to surveil. And I'm sure you had this discussion that a high-risk patient needs surveillance. Yes, I think it's one of the talks here, actually. And then a surveillance plan should be made. So that's, in our clinic, how we optimally deal with patients. Now, if you're sent to a skin cancer expert, it's only because somebody's labeling them a skin cancer expert. I have like multiple labels. Head of clinical research, phase 1, cutaneous. I see a lot of cutaneous melanoma. I see a lot of ocular melanoma. Head of the immuno-oncology department. People call me by different names. Good father, so-so husband. You just need to find the person that's the right.
Cell phone taker aware.
So you are getting surveillance.
Yes, I had my MRI last month, clean liver, which is cool. They're going to do that scan in October and go back to see Dr. in October.
Right. So one of the things, like on a busy day in my clinic, it's so nice to have a patient, and you see the scan, you go, hey Bob, good job, scans are clear, get out of my office. Right, come back in 6 months. That makes me feel good, makes the patient feel good. What really should be the discussion is clear. And here's what we've done if it comes back. And let me give you a snippet of what's coming up, in the field. Now that doesn't need to be every time you go there. But what I found is patients, specifically UM patients, are extremely well read. And you can ask them that. See, that's great, but when I go home, I always have this concern. What is the first thing we do if this comes back? Okay.
I'm at high risk, almost 3 years post brachytherapy, and I have like short telomeres, broken DNA. They're like imminent death. You're dying. You're dying. That's what I was told, almost 3 years ago. Everything was going good, but recently my liver has gone fatty, where it was pristine 6 months ago. And my oncologist said, great news, you don't have cancer. But my primary concern that it's turning into, since that's the high risk.
Right, so that's, there's a couple of things there that are run on parallel tracks but don't cross. So
Right.
fatty liver or NASH, non-alcoholic steatohepatitis, is something that happens in a lot of us. It happens based on our diet, obesity, alcohol intake, etc. So for you, you're getting screened. There's no evidence of a recurrence at this point. So the thing you should be saying is, if that happens, I need to make sure that my liver, my organs are in the best possible shape. So I have a great guy who I utilize, Vinay Sundaram, who is a hepatologist, who sees our patients who have this and discusses change in diet and pathways to improving the liver itself.
Well, they put me on a diet. So I've lost 20 pounds in 4 months. So
Share
my doctor is
share that diet with me.
Right. intermittent juice fasting.
Don't share that diet.
You're hungry when you go to bed.
But see, that's the important part, because some of these therapies may be toxic to the liver, and you don't want to start with a liver that already has some issue. The great news is that that type of damage can be reversed. Okay. Yes, ma'am.
I get castle as well as impact. Are we all tested for the DNA2? Or what? How do we get that done? What is that done?
Right. So not everyone is tested. It's not a standard, because what we haven't shown is that it leads to a therapy that has benefit in the long term. That's what we're trying to show now. How do you do that? You talk to your doctor about sending your tissue off for a next generation sequencing. So some places they do it locally in the hospital. I like some of the other places, like you've heard about Foundation One, you've heard about Tempest. I'll remember it. But they then run all of this genetic determination, the genetic load, the mutational load, the mutations themselves, etc. Now, as I told you before, ocular melanoma has a low mutational load, so you may not end up with much, but it is a starting point. Why? One of my wonderful patients is here, and we are now working to find the right trials, and so I've told this person, we can call Kim Julie, and we're now working and said, you know, when the trial at UCLA opens for CAR T, we'll send you there to send your tissue off to see if you have this, the staining for this tumor protein. We're waiting for one of these new RAS-targeted agent trials to open with my colleague Alan Mita at Sam Ocean Cancer Center. We're looking to find another phase 1 trial that doesn't exclude ocular melanoma, because that's somewhat the difficulty now with some of these immune drugs, because there hasn't been a lot of breakthrough that they're excluding ocular melanoma. So those are the things. Because hopefully you'll never need this, but I have patients who need this, who start out and you say, oh great, we're now stuck here in the first line. My first line trial is something which is immunotherapy, which is a standard immunotherapy, versus the IMC GP100 bispecific that has orphan designation by the FDA. So let's screen you for this trial, get you treated, and then if we need something else, then we know you have this mutation. I can send you here for this. And this is a point that I'll make later that I want to make now as we come to a conclusion. What has really helped is that some of these trials allow you to pre-screen. You pre-screen to see if you have this tumor marker. Pre-screen to see if you have MAGE or NY-ESO or PRAME or some of these proteins, so that you know if you have the right HLA type or all of this stuff. And you don't have to remember any of that. You have to talk to your doctor. They have to move you through this. And believe me, I'm not saying that every patient who has had a treatment and has no metastatic disease should be going and screening for metastatic trials. But the beginning is knowing the next generation sequencing, knowing some of the other things that make you ready to go. At Angeles, and I've been there for now 14 years, at Angeles we've been fortunate to be part of the FDA approval of somewhere of over 8 to 10 drugs, and it's just started this way. I'm hopeful that some of these ocular melanoma drugs will be added to that list. Yes?
Just a question on the next generation. So say you had the ocular melanoma and you got it like 10 years ago. So the sample was taken, you know kind of what you are, but all they did was one specific. And then say you do metastasize, where are you getting the next? Are you talking like if you metastasize to the liver, they take a piece of that, or?
You can always check based on the initial tumor itself. I always like to get a fresh tumor. Now, as an aside, if it's 10 years, I definitely biopsy just to make sure I know what it is.
Okay, but you're talking.
But I would biopsy that area.
Okay.
And then send that to the tumor.
So it has nothing to do with the eye from years ago or whatever. I know it's.
Yeah, it could be that same tumor.
It could be, but you can still get that information off of the new.
Yes,
if it metastases.
absolutely.
Okay.
Absolutely.
So it's not like what you had, what you know from the one doesn't mean you can't get any information later on.
Yes.
Okay.
Absolutely right.
I was a little confused about that.
What would be the relationship between cutaneous and ocular? Like, I've had 8 cutaneous melanoma since I was 17. My daughter is the only, she presents with that.
So I would, you need to see a cancer geneticist. There's no the fact that you have ocular melanoma doesn't make you a higher risk of having cutaneous melanoma, but there may be some genetic syndrome there that gives you a higher risk of both. Yes, the handsome man.
You know, I had to talk today. I'm just going to plug the Angelus Clinic, really, because I had another doctor, and pretty much couldn't go any further because there were no clinical trials to go into. And when I came down here, I didn't realize that how important it is, like you said, to have a team behind you. You know, when they came in, they just piled a bunch of people on me and said, "This is who this is," and you know, it really makes a big difference because on the emotional side of it, when I go down for my appointments in LA, it's like this team comes in and I get hope. You know, and that's the thing, is trying to hang on to hope, you know, no matter what. I think I'm one of his weirdest patients he's got so far today.
No, I would say to you, so I came down in an Uber, and my Uber driver was so hot about football season starting. He is a New Orleans fan, so I'm a Miami fan. It's not going to be a good year for us. But the main point is that those two teams are going to play each other, and they're going to come on a field just like you're battling. And I know my team, bad year for us. We won't be prepared. And every loss there is a difficulty. You want to be as prepared as possible to succeed, because there is no greater regret than failing and knowing that you didn't do as much as you could, that you weren't as prepared as you should be. That's the whole reason we're all here today. And I will tell you that part of being prepared is having no ego about who takes care of the patients. You know, we make calls to UCSF, to Stanford, to UCLA, Columbia, etc., Memorial, and there are better people than me who spend more time on ocular melanoma. Richard Carvajal, who's at Columbia, Sapna Patel, who's at MD Anderson. They spend the whole of their career writing these protocols and looking for answers. Jason Luke, who's now at UPMC in Pittsburgh. These people spend extensive amounts of time. Alex Shastari, who's at Memorial. So this is a network. You have 50 doctors looking after you. I think you need to feel that. Okay, taking someone else's time.